This short video shows excerpts from a lecture by Dr. Greg Miller. It's intended to give an example of how you might prepare your lectures in pathology for medical students, and also how in the second film Dr. Miller uses annotations to effectively point out to his students key features on his slides.
Hello, my name is Greg Miller, an anatomical pathologist at Envoy Specialist Pathologists and an associate lecturer here at the University of Queensland. I will be presenting the first of 3 lectures covering the major pathology scene in the luminal gastrointestinal tract. It will cover some of the major pathological entities seen in the upper gastrointestinal tract, being the oral cavity and salivary glands, the esophagus and the stomach. Each of the videos in this lecture will follow a similar outline. Firstly, a brief introduction to the anatomy and basic histology of the organ is presented, followed by the description of a number of benign and malignant entities seen in each location. Each video is approximately 20 minutes in length and should be a standalone précis of the major entities in that organ system. I hope you find these video lectures useful. The salivary glands are paired organs on each side of the face. There are 3 major salivary glands: the parotid, the submandibular and the sublingual salivary glands, as well as minor salivary glands spread throughout the oral cavity. Salivary gland secretions, or saliva, flow along ducts to enter the mouth to assist in activities such as carbohydrate digestion through the secretion of salivary amylase, lubrication through mucus production, and hygiene by the secretion of lysozyme, bicarbonate buffer, and the volume of saliva produced. I will briefly discuss both inflammatory and neoplastic conditions seen in the salivary glands. The microscopic anatomy of the salivary glands is that of secretory cells forming small acini, or gland-like structures, leading into a duct that traverses through the connective tissue and opens in the mouth. In the parotid gland, the secretory cells are predominantly serous cells. These purple-coloured cells here, which produce thin, watery fluid rich in enzymes and antibodies. In the sublingual glands, the secretion is predominantly mucus and is more viscous, as the mucus is produced by these cells here. The submandibular glands have a combination of both serous and mucus cells, as seen here. Inflammatory and neoplastic conditions are the most common pathological changes seen in the salivary glands. As the biggest gland, the parotid is the salivary gland most commonly affected. However, systemic conditions can affect all of the salivary glands simultaneously. Inflammation of a salivary gland is called sialadenitis. It has numerous causes, but the most common are infections caused by viruses and bacteria, traumatic injury, and autoimmune conditions affecting the gland. The most common viral cause of sialadenitis is mumps, a paramyxovirus. It causes painful swelling of the major, usually the parotid salivary glands, and can also affect other organs such as the testis, pancreas, and the brain. Sjogren's syndrome is an autoimmune condition that usually presents in older females with the dyad of dry mouth, xerostomia, and dry eyes, keratoconjunctivitis sicca, that is due to the immune-mediated destruction of salivary gland and lacrimal gland tissue. It can manifest as a primary autoimmune condition, or more commonly can occur secondary to other autoimmune conditions such as rheumatoid arthritis, systemic lupus, avasculitis, or thyroiditis. It is believed to be caused by an autoimmune T-cell reaction against an unknown, possibly viral antigen within the salivary glands. This manifests as an infiltration of T lymphocytes, B lymphocytes and plasma cells within the salivary glands that over time causes destruction of the tissue and replacement by fibrotic connective tissue. The diagnosis is made based on the clinical findings stated above, plus the presence of autoantibodies within the serum. Rheumatoid factor and anti-nuclear antibody are seen in more than half of the cases. More specific autoantibodies against the ribonucleoproteins SSA and SSB are more specific for the diagnosis of Sjogren's syndrome. Occasionally, a biopsy of a minor salivary gland, usually in the lip, is performed to confirm the diagnosis. Sjogren's is important not just because of the sometimes debilitating symptoms, but also because, in approximately 5% of cases, it can lead to the development of a B-cell lymphoma called mantle cell lymphoma. Mucoceles are common lesions of minor salivary glands that are caused by either blockage or traumatic rupture of a salivary gland duct. Rupture leads to extravasation of mucus and the generation of a fluctuant, bluish swelling that can enlarge and spread into the adjacent soft tissues. Treatment is with complete surgical excision. Sialolithiasis is the generation of a stone within the salivary gland duct. It most commonly occurs in the submandibular gland. It is usually unilateral and will often cause a fluctuant mass in the floor of the mouth that enlarges when eating. Stones can be caused by any blockage of the duct or by a decrease in saliva production. Blockage of the duct can lead to a non-specific bacterial sialadenitis, usually secondary to Staphylococcus aureus or Streptococcus viridans. Now, there are over 30 different histological types of benign and malignant tumours that can affect the salivary glands. Most of these are benign, and the parotid gland is the most commonly affected of these salivary glands. Salivary gland tumours are usually seen in older males, and they typically present with unilateral swelling of the face. The most common salivary gland tumour is the pleomorphic adenoma, so named because of its varied microscopic appearance. They contain a variable mixture of both ductal and myoepithelial cells, and hence have both epithelial and mesenchymal components. They typically present as an expansile encapsulated mass in the parotid gland, and on sectioning, the surface is cream, shiny and glistening. The histological features show great heterogeneity, with the epithelial component showing glands, tubules and sheets of cells set in a mesenchymal structure demonstrating myxoid, chondroid, which is cartilage-like, and even osseous or bone-like areas. Treatment is with parotidectomy, as simple enucleation can lead to recurrences in approximately 25% of cases. Rarely, pleomorphic adenomas can turn malignant, and this is called a carcinoma ex pleomorphic adenoma. The cancer is usually an adenocarcinoma, and if it invades through the capsule of the original pleomorphic adenoma, it is an aggressive lesion with a 30 to 50% mortality at 5 years. The other common benign tumour is a Warthin's tumour. These occur in the parotid glands of older male smokers and present as a slow-growing, painless mass. The cut surface is grey with slit-like spaces containing dark grey machine oil-like fluid. The microscopic appearance is that of fronds of tissue lined by 2 layers of eosinophilic cuboidal cells, termed oncocytic cells, that are surrounded by a dense inflammatory cell infiltrate. These tumours do not undergo malignant transformation. Mucoepidermoid carcinoma is the most common malignant tumour of the salivary glands, accounting for approximately 15% of all the mass lesions seen. They usually occur in the parotid, but can occur in other salivary glands, including the minor salivary glands. Histologically, they show a mixture of glandular cells, squamous cells, and cells with an intermediate phenotype. Outcome for these lesions is based on the differentiation of the components, or how wild the cell looks. Interestingly, in over 50% of cases of mucoepidermoid carcinoma, there is a balanced chromosomal translocation involving chromosomes 11 and 19, which leads to a fusion protein that appears to play a key role in the pathogenesis of this tumour. The last salivary gland tumour I will talk about is the adenoid cystic carcinoma. These are slow-growing tumours that often occur in the minor salivary glands. They are composed of small cells arranged into tubular or cribriform patterns interspersed with hyaline material. Although slow-growing, these lesions have a tendency to extensively infiltrate nerves, causing recurrent disease over many years.